Celiac disease overview. A. Characteristic symptoms and pathophysiology. Celiac disease is an autoimmune disorder triggered by dietary gluten in genetically predisposed individuals, leading to small intestinal mucosal injury. Key pathological features include villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes in the proximal small intestine. B. Clinical presentation and diagnosis. Symptoms can vary widely, including diarrhea, weight loss, abdominal pain, and extraintestinal manifestations like dermatitis herpetiformis, anemia, and osteoporosis. Diagnosis. Serology. First-line tests include IgA anti-tissue transglutaminase (TTG) antibodies, with total IgA levels checked to rule out IgA deficiency. In IgA-deficient cases, IgG-based tests, e.g. IgG-TTG, IgG-deamidated gliadin peptide, are used. Endoscopy with biopsy. Gold standard for diagnosis, showing characteristic histopathological changes in the small intestine, such as villus atrophy and crypt hyperplasia. HLA typing may be used to rule out celiac disease if negative, as virtually all celiac patients carry HLA-DQ2 or HLA-DQ8. C. Treatment. Gluten-free diet. Lifelong adherence to a diet devoid of wheat, rye, barley, and derivatives is the cornerstone of treatment, leading to symptom resolution and mucosal healing. Nutritional support. Address deficiencies such as iron, calcium, vitamin D, and B vitamins as needed based on individual assessments. D. Prognosis. With strict adherence to a gluten-free diet, most individuals have a good prognosis, with a significant improvement in symptoms and a decreased risk of associated malignancies. Differential diagnosis considerations. Tropical sprue, differentiated by geographical history and response to antibiotics. Whipple disease, identified by PAS-positive foamy macrophages in the intestine and a broader spectrum of systemic symptoms. Irritable bowel syndrome, IBS, lacks the autoimmune and histopathological features of celiac disease. High yield points. Suspect celiac disease in patients with diarrhea, weight loss, or unexplained nutritional deficiencies, especially if there's a family history or associated autoimmune conditions. Initial testing with TTG-IgA antibodies, followed by duodenal biopsy in seropositive cases, is key to diagnosis. The only effective treatment is a lifelong gluten-free diet, which can lead to symptom resolution and decreased risk of complications. Regular follow-up with dietary counseling and monitoring for nutritional deficiencies is essential for managing celiac disease. Clinical case, celiac disease. Patient information, age 28 years, sex female, occupation graphic designer. Presenting complaint. The patient presents with a 6-month history of progressive fatigue, unintentional weight loss of 10 pounds, and recurrent abdominal bloating and discomfort, especially after meals. She also reports chronic diarrhea, with stools described as bulky and foul-smelling. Medical history. No significant past medical or surgical history. No known drug allergies. The patient mentions that her mother has type 1 diabetes mellitus. Social history. Non-smoker, occasional alcohol use. No recent travel history. The patient follows a typical Western diet with no recent changes. Physical examination. General, appears mildly cachectic, no acute distress. Vitals, BP 110 70 mmHg, HR 78 BPM, temp 98.6 diphras, RR 16 min. Abdomen mild distension, diffuse tenderness on palpation, no rebound or guarding. Skin, examination reveals a few erythematous, pruritic papules over the extensor surfaces of the arms and legs. Other systems, unremarkable. Initial investigations, CBC, mild microcytic anemia. CMP, normal electrolytes, mildly elevated liver enzymes. Iron studies, low serum iron and ferritin levels indicating iron deficiency anemia. Further diagnostic workup, serological tests, positive for IgA anti-tissue transglutaminase antibodies, TTG-IgA. Total IgA levels are within normal range. Endoscopy with duodenal biopsy shows villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes consistent with celiac disease. Diagnosis, based on the clinical presentation, serology, and biopsy findings, a diagnosis of celiac disease is confirmed. Management. Dietary. The patient is referred to a dietitian specializing in gluten-free diets and advised to strictly avoid all sources of gluten, wheat, barley, rye. Supplementation. Initiated on iron supplements for anemia and advised on a diet rich in calcium and vitamin D to prevent osteoporosis. Follow-up, scheduled for follow-up in 3 months to assess response to the gluten-free diet and improvement in symptoms. Plans for repeat serology and possible repeat endoscopy after 6 to 12 months to assess mucosal healing. Outcome. At the 3-month follow-up, the patient reports significant improvement in gastrointestinal symptoms and general well-being. Her fatigue has lessened, and she has gained back some weight. Repeat blood tests show improvement in anemia and normalization of liver enzymes. Discussion. This case illustrates a typical presentation of celiac disease in an adult, highlighting the importance of considering this diagnosis in patients with chronic gastrointestinal symptoms and associated conditions like dermatitis herpetiformis and iron deficiency anemia. It underscores the pivotal role of serological testing and confirmatory biopsy in diagnosis and the effectiveness of a gluten-free diet in managing symptoms and preventing complications. Oral exam questions and answers on celiac disease. Question 1. What are the classic histopathological features of celiac disease observed in a small bowel biopsy? A. The classic histopathological features of celiac disease include villus atrophy, a reduction in the height of the small intestinal villi leading to a flat mucosal surface; crypt hyperplasia, an increase in the depth of the intestinal crypts; increased intraepithelial lymphocytes, more than 25 lymphocytes per 100 enterocytes in the epithelium. These changes contribute to the malabsorption symptoms seen in celiac disease due to the decreased surface area for nutrient absorption. Question 2. Q. Explain why serological tests might return negative in a patient with celiac disease and how you would proceed with diagnosis in such a case. Serological tests might return negative in cases of selective IgA deficiency, which is more common in patients with celiac disease than in the general population. In such cases, testing for IgG-based antibodies, e.g. IgG-TG or IgG-deamidated gliadin peptide, should be performed. If clinical suspicion remains high despite negative serology, an endoscopic biopsy of the small intestine should be considered for definitive diagnosis. HLA typing for HLA-DQ2 and HLA-DQ8 might also be useful, as the absence of these alleles has a high negative predictive value for celiac disease. Question 3. Describe the management of celiac disease and the rationale behind it. The cornerstone of managing celiac disease is a strict, lifelong gluten-free diet, which involves eliminating all sources of gluten found in wheat, barley, rye, and their derivatives from the diet. This diet helps in the healing of the intestinal mucosa, resolution of symptoms, and prevention of disease-related complications. In addition to dietary management, patients may require supplementation of nutrients they were deficient in at diagnosis, such as iron, calcium, vitamin D, and B vitamins. Regular follow-up with serological tests and possibly repeat endoscopy is recommended to assess adherence to the diet and mucosal healing. Q. What are some potential complications of untreated celiac disease? A. Untreated celiac disease can lead to a variety of complications, including nutritional deficiencies due to malabsorption, e.g. iron deficiency anemia, osteoporosis, increased risk of certain malignancies such as enteropathy-associated T-cell lymphoma and small intestinal adenocarcinoma, development of other autoimmune disorders such as type 1 diabetes mellitus and autoimmune thyroiditis, dermatitis herpetiformis, a skin manifestation of celiac disease. In children, untreated celiac disease can lead to failure to thrive, delayed puberty, and stunted growth. These questions encompass key aspects of celiac disease, from its pathophysiology and diagnostic approach to management strategies and potential complications, reflecting the comprehensive knowledge expected from medical professionals. The differential diagnosis of an abdominal tumor encompasses a wide range of conditions varying by age, location of the tumor, presenting symptoms, and imaging characteristics. Here's a structured approach to consider. In adults, A. Upper abdomen, liver, hepatocellular carcinoma, liver metastases, hepatic adenoma, focal nodular hyperplasia. Pancreas, pancreatic adenocarcinoma, pancreatic cystic neoplasms, e.g., serous cystadenoma, mucinous cystic neoplasm, neuroendocrine tumors. Gallbladder and biliary tract, gallbladder cancer, cholangiocarcinoma. Kidneys, renal cell carcinoma, angiomyolipoma, oncocytoma. B. Mid-abdomen, gastric cancer, gastrointestinal stromal tumor, GIST, gastric lymphoma. Small intestine, small bowel adenocarcinoma, carcinoid tumors, GIST lymphoma. Adrenal glands, adrenal adenoma, adrenal carcinoma, pheochromocytoma. C. Lower abdomen, colon and rectum, colorectal cancer, lymphoma, GIST. Ovaries in females, ovarian carcinoma, benign ovarian cysts, ovarian cystadenoma, endometrioma. Uterus in females, leiomyoma, fibroids, uterine sarcoma, endometrial cancer. Bladder, bladder cancer, bladder diverticulum. In children, A. Upper abdomen, liver, hepatoblastoma, younger children, hepatocellular carcinoma, older children. Kidneys, Wilms tumor, nephroblastoma, renal cell carcinoma, rare in children. B. Mid to lower abdomen, neuroblastoma. Often arises in the adrenal gland but can occur anywhere along the sympathetic chain. Teratoma can occur in various locations, including sacrococcygeal area. Lymphoma can present as abdominal masses, often associated with systemic symptoms. Germ cell tumors, including ovarian and testicular tumors in adolescents. Common considerations across ages. Avascular, aortic aneurysm, more common in older adults, can present as a pulsatile abdominal mass. Renal artery aneurysm, less common, may present incidentally. B. Inflammatory, abscess, can arise from various intra-abdominal infections. Inflammatory bowel disease can lead to mass-like inflammatory strictures. C. Functional or benign conditions. Cysts, simple cysts in the liver, kidney, pancreas, or ovaries. Hemangioma, commonly found in the liver. D. Miscellaneous endometriosis can form mass-like lesions, particularly in the pelvis. Retroperitoneal fibrosis can encase abdominal organs, leading to a palpable mass. Diagnostic approach, clinical history and physical examination. Age, sex, location of the tumor, and associated symptoms can narrow down the differential diagnoses. Imaging, ultrasound, CT scan, MRI provide crucial information about the location, size, and characteristics of the tumor. Laboratory tests, blood tests including tumor markers, liver and renal function tests. Biopsy, essential for definitive diagnosis, guiding through fine needle aspiration or core biopsy under imaging guidance. The differential diagnosis should be tailored based on specific patient factors and clinical presentation, with a multidisciplinary approach often necessary for accurate diagnosis and management. Aortic stenosis, AS. Overview. A. Characteristic symptoms and pathophysiology. AS is characterized by narrowing of the aortic valve, obstructing blood flow from the left ventricle to the aorta. This obstruction leads to compensatory left ventricular hypertrophy and eventually heart failure if untreated. Common symptoms, when they appear, include dyspnea on exertion, angina pectoris, and syncope. B. Clinical presentation and diagnosis. Physical exam, notable for a systolic crescendo-decrescendo murmur, delayed and diminished carotid pulses, pulsus parvus et tardus, and possibly a systolic thrill. Echocardiography, gold standard for diagnosis, assessing valve anatomy, stenosis severity, and ventricular function. Other diagnostics, ECG might show signs of left ventricular hypertrophy, chest X-ray can indicate cardiac remodeling. C. Treatment, conservative. Asymptomatic patients with mild AS or moderate AS are monitored with routine echocardiography and managed for related conditions like hypertension. Surgical intervention, indicated for symptomatic patients or those with severe AS, with options including surgical aortic valve replacement, SR, and transcatheter aortic valve replacement, depending on patient age, surgical risk, and comorbidities. D. Prognosis. Prognosis is favorable with timely intervention, but untreated symptomatic AS has a high mortality rate. Differential diagnosis. Considerations. Mitral regurgitation, differentiated by its holosystolic murmur and apical impulse. Hypertrophic cardiomyopathy, HCM. Murmur intensity increases with maneuvers like Valsalva, unlike AS. Aortic regurgitation presents with a diastolic murmur and bounding pulses, which are not features of AS. High yield points. AS often remains asymptomatic until severe. Thus, a high index of suspicion is necessary in patients with risk factors and suggestive auscultatory findings. Severe AS necessitates valve replacement regardless of symptoms, given the poor prognosis with medical management alone. Choice between SAVR and TAVR is influenced by patient-specific factors, including age, comorbidities, and surgical risk. Hacked management strategy 1. Asymptomatic patients. Regular monitoring with echocardiography. Management of cardiovascular risk factors. 2. Symptomatic patients or severe AS. Aortic valve replacement is the definitive treatment. SAVR is preferred in younger, lower-risk patients. TAVR is considered for older, higher-risk patients or those contraindicated for surgery. 3. Acute complications. Management of heart failure, arrhythmias, and other acute complications in the setting of severe AS requires urgent attention and can necessitate expedited valve replacement. Clinical case, aortic stenosis. Patient information, age, 72 years, sex, male, occupation, retired teacher. Presenting complaint. The patient presents with increasing shortness of breath on exertion over the past 6 months, episodes of chest pain resembling angina, and a recent episode of syncope after climbing stairs. Medical history. Hypertension, controlled with medication, hyperlipidemia, no previous history of heart disease or rheumatic fever, family history of coronary artery disease. Social history. Non-smoker, occasional alcohol use, lives alone, active in the community. Physical examination, general, appears well-nourished but slightly dyspneic after walking to the examination room. Vitals, BP 130 80 milligrams, HR 68 BPM, regular, temp 98.6 Faris, RR 16 cardiovascular, notable for a harsh systolic crescendo-decrescendo murmur, best heard at the right second intercostal space radiating to the carotids. Diminished and delayed carotid pulses noted, no jugular venous distension. Respiratory, clear to auscultation bilaterally. Abdomen, soft, non-tender, no organomegaly. Extremities, no peripheral edema. Initial investigation, Z-stage, shows left ventricular hypertrophy with strain pattern, chest X-ray. Normal heart size, no pulmonary congestion. Further diagnostic workup. Echocardiography reveals severe aortic stenosis with a valve area of 0.8 centimeters, mean gradient of 50 mmHg, and preserved left ventricular ejection fraction. Diagnosis, severe symptomatic aortic stenosis. Management. The patient was started on beta blockers for angina management and referred for urgent evaluation by a cardiac surgeon. After multidisciplinary team discussion, considering the patient's age and comorbidities, it was decided to proceed with transcatheter aortic valve replacement, TAVR. The procedure was successful, and the patient was discharged with follow-up in the heart valve clinic. Outcome. At a 3-month follow-up, the patient reports significant improvement in exercise tolerance and no further episodes of chest pain or syncope. Repeat echocardiography shows improved valve function with reduced gradient across the aortic valve. Discussion. This case illustrates a typical presentation of severe symptomatic aortic stenosis in an elderly patient. It highlights the importance of a detailed history and physical examination in raising suspicion for the disease, which is then confirmed by echocardiography. Given the patient's symptoms and severity of stenosis, intervention was necessary, and TAVR was chosen over SAVR due to the patient's age and risk profile, reflecting current trends in the management of aortic stenosis. Oral exam questions and answers on aortic stenosis. Question 1. What are the classical symptoms of severe aortic stenosis and their physiological basis? The classic triad of symptoms in severe aortic stenosis includes dyspnea on exertion, angina pectoris, and syncope. Dyspnea. results from increased left ventricular LV diastolic pressure and pulmonary venous hypertension due to reduced LV compliance and impaired filling. Angina occurs due to increased myocardial oxygen demand from LV hypertrophy and reduced coronary artery perfusion during diastole, despite possibly normal coronary arteries. Syncope may occur due to a fixed cardiac output during exertion, arrhythmias, or vasovagal reflexes. Question 2. Q. Describe the auscultatory findings in a patient with aortic stenosis and explain the changes during the cardiac cycle. In aortic stenosis, auscultation typically reveals a harsh crescendo-decrescendo systolic murmur best heard at the right second intercostal space, radiating to the carotids. The murmur peaks in mid-systole due to the maximal velocity of blood flow across the narrowed aortic valve. There may also be an aortic ejection click early in systole, diminished S2, and occasionally the presence of an S4 due to forceful atrial contraction against a stiffened left ventricle.
Question 3.
How is the severity of aortic stenosis assessed echocardiographically, and what are the key parameters? Echocardiography assesses the severity of aortic stenosis primarily through the following measurements. Aortic valve area. Severe stenosis is defined by an AVA of less than 1.0 centimeters. Mean gradient. A mean pressure gradient greater than 40 millihg across the aortic valve indicates severe stenosis. Peak jet velocity. Velocities greater than 4 meters per second also suggest severe stenosis. Additional echocardiographic signs include LV hypertrophy and post-stenotic dilation of the ascending aorta. Question 4. Q. What are the indications for aortic valve replacement in patients with aortic stenosis? A. Aortic valve replacement, AVR, is indicated in symptomatic patients with severe AS regardless of LV systolic function due to the poor prognosis associated with symptomatic AS. Asymptomatic patients with severe AS and either LV systolic dysfunction EF 50%, rapid progression of AS, excessive LV hypertrophy, or abnormal exercise testing showing symptoms or a fall in blood pressure. Patients undergoing cardiac surgery for other indications who also have moderate or severe AS. These questions cover the essential aspects of aortic stenosis, including its clinical presentation, diagnostic evaluation, and indications for treatment, reflecting the comprehensive understanding required in the medical field. Chapter Pulmonary Embolism, PE, Overview. A. Characteristic symptoms and pathophysiology. PE results from the obstruction of pulmonary arteries, commonly by thrombi originating from deep veins, DVT, leading to impaired gas exchange and increased pulmonary artery pressure. Symptoms vary widely but can include acute dyspnea, chest pain, especially pleuritic, cough, and systemic signs like tachycardia and hypoxemia. B. Clinical presentation and diagnosis. Physical examination may reveal tachypnea, tachycardia, signs of DVT, and in severe cases, signs of right heart strain. D-dimer. Highly sensitive but not specific, used to exclude PE in low-risk patients. Imaging. CT pulmonary angiography, CTPA, is the gold standard for diagnosis, showing direct evidence of pulmonary artery obstruction. Echocardiography and ECG, useful in assessing right ventricular strain and hemodynamic stability. C. Treatment. Anticoagulation. The cornerstone of PE treatment. Choices include low molecular weight heparin, LMWH, unfractionated heparin, UFH, and direct oral anticoagulants, DOACs. Reperfusion therapy, reserved for hemodynamically unstable patients, massive PE, or selected cases of submassive PE with high-risk features. Options include thrombolysis, surgical embolectomy, or catheter-directed therapies. Supportive care includes oxygen supplementation, analgesia, and management of underlying conditions. D. Prognosis and complications. Prognosis depends on the severity of PE, the presence of hemodynamic instability, and timely initiation of treatment. Complications can include chronic thromboembolic pulmonary hypertension, CTEP, recurrent embolism, and right heart failure. High yield points. Consider PE in the differential diagnosis for acute dyspnea, especially with a history of DVT risk factors. D-dimer testing is useful in ruling out PE in patients with low pretest probability. CTPA is the diagnostic modality of choice for confirming PE. Early initiation of anticoagulation is critical in the management of PE to prevent further embolic events and stabilize clot burden. Differential diagnosis considerations. Deep vein thrombosis, DVT, often coexists with PE as part of venous thromboembolism, VTE. Acute coronary syndrome, ACS, similar presenting symptoms like chest pain and shortness of breath. Acute aortic dissection can present with acute chest pain and is a differential for PEE on imaging. Pneumonia or acute bronchitis. Respiratory infections can mimic the symptoms of PE, but usually have localized signs on examination and imaging. Clinical case, pulmonary embolism. Patient information, age, 55 years, sex, female, occupation, presenting complaint. The patient presents to the emergency department with sudden onset shortness of breath and right-sided chest pain that worsened over the last 6 hours. The pain is sharp and intensifies with deep breaths. Medical history. Hormone replacement therapy for menopausal symptoms. No history of heart disease or hypertension. No previous episodes of similar symptoms. Social history. Non-smoker. Sedentary lifestyle. Recently returned from a long-haul flight, 12 hours, 3 days ago. Physical examiner's distress due to dyspnea. Vitals, BP 120 80 millimeter grams, HR 110 BPM, temp 98.6 degree, RR 22 min, O2 saturation 92% on room air. Cardiovascular, tachycardic with no murmurs, rubs, or gallops. Respiratory, tachypneic, decreased breath sounds at the right base with mild pleuritic rub. Extremities, mild right calf swelling and tenderness on palpation. Initial investigations, ECG, sinus tachycardia, nonspecific STT wave changes, chest x-ray, no evidence of consolidation, small right-sided pleural effusion. D-dimer, elevated further diagnostic workup. Given the high clinical suspicion for PE, a CT pulmonary angiography, CTPA, was performed, confirming the presence of a large embolus in the right pulmonary artery. Diagnosis, acute pulmonary embolism. Management. The patient was started on intravenous unfractionated heparin immediately after the CTPA. Due to hemodynamic stability but evidence of right ventricular strain on echocardiography, the patient was admitted to the high dependency unit for close monitoring. A lower extremity Doppler ultrasound confirmed deep vein thrombosis in the right calf. The patient was transitioned to direct oral anticoagulant, DOAC therapy on the second day of admission, with a plan for at least 3 months of treatment. Outcome. The patient's symptoms improved significantly with treatment. She was discharged with instructions for follow-up and lifestyle modifications to reduce the risk of future thromboembolic events. Discussion. This case illustrates a classic presentation of pulmonary embolism with risk factors including prolonged immobility due to a long-haul flight and hormone replacement therapy. The prompt use of CTPA enabled rapid diagnosis and immediate anticoagulation was crucial for preventing further embolic events and stabilizing the existing clot. This case underscores the importance of considering PE in patients presenting with acute unexplained dyspnea, especially with relevant risk factors. Oral exam questions and answers on pulmonary embolism. Question 1. Q. What are the primary mechanisms by which a deep vein thrombosis, DVT, leads to a pulmonary embolism, PE? A. A DVT, often originating in the deep veins of the legs or pelvis, can dislodge and become an embolus that travels through the venous system, passing through the right side of the heart to lodge in the pulmonary arteries. This embolization obstructs pulmonary blood flow, leading to impaired gas exchange, increased pulmonary artery pressure, and potential right ventricular strain. Question 2. Q. How does the Wells score aid in the diagnosis of PE, and what are its components? The Wells score is a clinical decision tool used to estimate the probability of PE in a patient based on clinical criteria and history. It includes factors such as signs of DVT, an alternative diagnosis less likely than PE, heart rate over 100 BPM, immobilization or surgery in the previous 4 weeks, previous DVT-PE, hemoptysis, and cancer. The score categorizes patients into low, moderate, or high probability for PE, guiding the need for further diagnostic testing, such as D-dimer assay or CT pulmonary angiography. Question 3. Describe the role and rationale of D-dimer testing in the workup of suspected PE. D-dimer is a fibrin degradation product present in the blood after a blood clot is degraded by fibrinolysis. It is highly sensitive but not specific for thrombosis. In patients with a low or moderate clinical probability of PE, a normal D-dimer level can effectively rule out PE, given the test's high negative predictive value. However, elevated D-dimer levels are not specific to PE and can be elevated in other conditions. Therefore, its primary use is to exclude PE in patients with low clinical suspicion. Question 4. What is the preferred imaging modality for the definitive diagnosis of PE and why? A. CT pulmonary angiography, CTPA, is the preferred imaging modality for diagnosing PE due to its high sensitivity and specificity for detecting pulmonary artery obstructions. CTPA provides detailed images of the pulmonary vasculature, allowing direct visualization of emboli. It also offers the ability to assess for alternative diagnoses that may explain the patient's symptoms. Question 5. What are the mainstays of treatment for PE and the indications for thrombolytic therapy? The mainstay of treatment for PE is anticoagulation therapy to prevent further clot formation and allow the body to naturally lyse the existing clot. This typically involves the initial use of parenteral agents like unfractionated heparin or low molecular weight heparin, followed by longer-term anticoagulation with vitamin K antagonists or direct oral anticoagulants. Thrombolytic therapy is reserved for patients with massive PE and hemodynamic instability, e.g., sustained hypotension, shock, or severe right ventricular dysfunction, as it rapidly dissolves the clot but carries a higher risk of bleeding. These questions cover the essentials of pulmonary embolism, from pathophysiology and diagnosis to management, reflecting the depth of understanding expected from medical professionals in a clinical setting.